Hello everybody. Today's topic is the connection between fluoroquinolone antibiotics and benzodiazepines. If you are someone that consistently takes benzodiazepines, you are also someone that frequently takes antibiotics, you really need to watch this video. Fluoroquinolone antibiotics, unlike most other antibiotics, are neurologically active at commonly prescribed dosages. As an action secondary to their primary antimicrobial effect, they are capable of binding to certain receptors in the brain, spinal cord, and peripheral nervous system. The primary receptor affected is the GABA-A receptor, which is the exact same receptor that benzodiazepines act on. And what the heck is GABA anyway? GABA, which stands for gamma-aminobutyric acid, is a key neurotransmitter that helps regulate brain activity by reducing excessive neuronal firing. It also inhibits overstimulation, which is crucial for reducing anxiety and depression and preventing epilepsy. There are two types of GABA, GABA-A and GABA-B, but benzodiazepines and fluoroquinolones are focused on GABA-A. When a fluoroquinolone binds to a GABA receptor, the result is the polar opposite of the effect of CNS depressants like benzodiazepines. Fluoroquinolones are antagonists of the GABA-A receptor, meaning that they prevent the binding of GABA and can displace other molecules bound to the receptor, such as benzodiazepines. GABA is an inhibitory neurotransmitter, and drugs which enhance its action like benzodiazepines cause sedation. The GABA receptor blockade caused by a fluoroquinolone results in a CNS stimulant effect with neurological manifestations ranging from mild insomnia and agitation to hallucinations and seizures. Anyone can suffer these side effects, but individuals prescribed benzodiazepines are notably much more prone to experiencing these adverse neuropsychiatric reactions. The culprit is the GABA receptor downregulation imposed by benzodiazepine intolerance. When a benzodiazepine is given chronically, beyond 10 days, there are a series of downward compensatory mechanisms which seek to restore a neurological equilibrium in the light of overstimulation of GABA receptors by the drug. This results in GABA receptors becoming progressively less receptive to GABA over time following prolonged exposure to benzodiazepines. Over time, the brain's GABA-dependent systems are weakened and there is a heightened vulnerability to external influences which decrease the action of GABA. A perfect storm ensues when a fluoroquinolone unmasks the GABA receptor downregulation associated with benzodiazepine tolerance. In addition, since they share the same target, fluoroquinolones are capable of competing with benzodiazepines for GABA receptor binding in a concentration-dependent manner. Studies have shown a complex interaction when a fluoroquinolone and a benzodiazepine are simultaneously bound to a GABA receptor. At high concentrations, fluoroquinolones are capable of displacing a portion of the benzodiazepine molecules bound to GABA receptors. This displacement can precipitate an acute benzodiazepine withdrawal syndrome, which is identical to that which would normally happen if an individual were to suddenly reduce their benzodiazepine dosage. It has been shown that certain non-steroidal anti-inflammatory drugs like NSAIDs, like ibuprofen, are capable of enhancing the GABA receptor blockade caused by fluoroquinolones, potentiating their neurotoxicity and exacerbating their CNS side effects. NSAIDs are frequently co-prescribed with fluoroquinolone antibiotics for painful infections like sinusitis and urinary tract infections. Many healthcare practitioners outside the realm of neuroscience are unaware of these lesser-known facts about fluoroquinolones and benzodiazepines. Pharmacists are usually not aware of the issue either and will readily dispense fluoroquinolone prescriptions to benzodiazepine-dependent patients. This interaction is not consistently recognized, yet it very consistently gets benzodiazepine-tolerant individuals into deep trouble. Studies have found that benzodiazepine-dependent individuals frequently experience depression, anxiety, psychosis, paranoia, severe insomnia, paresthesia, tinnitus, hypersensitivity to light and sound, tremors, seizures, and suicidal thoughts upon exposure to fluoroquinolone antibiotics. These symptoms are all consistent with acute benzodiazepine withdrawal syndrome. Furthermore, it may take several weeks or even months after discontinuing the fluoroquinolone for the affected individual to become symptom-free. Some individuals never return to their pre-fluoroquinolone state, and they are commonly referred to as having been floxed. They are left with conditions including peripheral neuropathy, muscle weakness, cognitive dysfunction, new or worsened mental illness, and even paralysis, which are all consistent with neurotoxicity and brain damage. It is imperative that healthcare professionals become aware of this dangerous interaction, which has rendered normal, healthy people disabled. Fluoroquinolones should be contraindicated with chronic benzodiazepine exposure in nearly every scenario, including non-medical benzodiazepine use. However, relying on the healthcare system alone is not enough. It is equally important that benzodiazepine-dependent individuals become aware of this interaction so that they can better advocate for themselves. As a reminder, the FDA states that due to the potentially permanent and disabling side effects of fluoroquinolone antibiotics, They should be used as last resort only when no other treatment options are available. If a clinician is trying to prescribe you a fluoroquinolone antibiotic, not as last resort, ask for an alternative if there is one. And if you are a consistent user of benzodiazepines, you definitely need to ask for an alternative. Most of the medical community does not know this, so you have to advocate for yourself. This is your life, your health, and no one cares about it more than you. You need to save yourself. There are even studies published from the National Institute of Health acknowledging this connection between fluoroquinolone antibiotics and benzodiazepines. Studies confirm that adverse reactions to fluoroquinolones occur more frequently in the benzodiazepine-dependent population. It has also been advised that in rare cases where it has been determined that failing to administer a fluoroquinolone could result in death, benzodiazepine-dependent individuals should have their benzodiazepine dosages increased for the entire duration of fluoroquinolone therapy. So again, if you are someone that consistently takes benzodiazepines and takes antibiotics, you really want to make sure you avoid fluoroquinolone antibiotics if possible for 2 reasons. The first one, to not go into automatic withdrawal, and the second one is to not become super floxed. I can speak from experience. I'm super floxed. I did not take benzodiazepines when I was prescribed ciprofloxacin, but when I was prescribed ciprofloxacin, I was taking NSAIDs at the advice of the emergency room doctor around the clock. I will post all of the sources where I gathered this data. Some information came from the National Institute of Health, but a good portion of the data came from Brad Verrett, who was a biochemist and former medical student that was employed at the Dow Chemical Company. Brad had a benzodiazepine injury from Xanax that began in 2011 as an undergrad student, continuing to suffer until 2016. Brad enjoyed using his free time to spread awareness of this topic. But unfortunately, Brad passed away in 2017. Hope this video was informative and explained why chronic benzodiazepine users should avoid fluoroquinolone antibiotics if possible. And remember, benzodiazepine user or not, if you're ever prescribed a fluoroquinolone as first line, ask for an alternative if there is one. That's all I got. Thanks, everybody.